Good morning. I'm Greg Salisbury. I'm the Editor-in-Chief of City and State Pennsylvania. I'd like to welcome you to the 2025 Healthcare Summit. I'd like to start by thanking our sponsors, UPMC Health Plan, Moravia Health, the Hospital and Health System Association of Pennsylvania, PHCA, the Wright Center for Community Health, and Jackson Kelly. Today's summit features a digital program book. If you'll scan the QR code at your table, that will give you all the information about our panels, our panelists, and our speakers. Today we're also using a new technology for the Q&A portion of our panels. This is called Slido. Partway through the panel, you'll see up on that screen, there will be the Slido name and a QR code. If you scan the QR code, it'll allow you to enter your questions in real time anonymously. You don't have to sign up for anything. We're going to start off with our keynote speaker, Dr. Val Arkush. She's the Secretary of the Pennsylvania Department of Human Services. Dr. Arkush.
Good morning, folks. Too many friends in this room. I'm in the back chatting, so sorry I wasn't up here a little more promptly. But thank you so much for the introduction, and it is terrific to be here with all of you. As you heard, I am Dr. Val Arkush, and I have the incredible honor of serving as the Secretary for the Pennsylvania Department of Human Services. And I think, well, first, actually, I very much want to acknowledge the tragedy, the air tragedy in Washington, D.C. Just, maybe take a moment to think about those folks. Apparently there were no survivors, which is just heartbreaking. So just want to acknowledge that for a moment in this very busy week. And it has been a very busy week so far. Many of you know I was a county commissioner during the COVID-19 epidemic and was a very public-facing daily news briefings for 3 or 4 months. And back then it was all about masks, and I think maybe we should all order some whiplash collars. That is my medical suggestion to all of you. It has been really quite a week. There's no doubt, if there ever was any, that new directives and rules are going to come out of President Trump's administration very quickly and perhaps in a manner that is not the type of manner that we're used to when the federal government issues new rules and guidelines. And so we're all just going to have to be ready to take it day to day and know that what happens on one day might be reversed the next day. And this is just going to be our new reality for some period of time here. But what I want you to know is that myself, my team, we are working every day to support the healthcare and other needs of Pennsylvanians, and we are ready to meet this moment, and so is this administration. I am laser focused on building and supporting bridges to success for the Pennsylvanians that we serve. We'll share information about the impact of proposed cuts to these services, but we'll also look for opportunities to partner with this new administration in any way that we can that would benefit Pennsylvanians. This approach to meeting challenges and problem solving is core to how I lead the Department of Human Services. As many of you know, I began my career practicing medicine as an obstetric anesthesiologist in Philadelphia teaching hospitals. However, I grew up in Nebraska and went to medical school at the University of Nebraska College of Medicine. I've experienced the challenges to access and delivery of health care in both rural and urban communities. My goal, and the goal of the Shapiro administration, is to ensure that Pennsylvanians can get the care they need, when they need it, and have access to the high quality of care and supports that they deserve, no matter where they live. And our solutions must treat the whole person. If a person can't access essential health treatments like specialty or behavioral health care or services, then we're not meeting the need. And I want to be clear that meeting the need extends beyond the exam room. I experienced that firsthand, practicing in Philadelphia, where I often found that the health of my patients was impacted by lack of transportation, limited access to healthy food or to safe housing, poverty wages, and gun violence. In order to be healthy, so many of my patients needed stable housing and safe neighborhoods, clean air to breathe and clean water to drink, or simply a grocery store in their neighborhood that sold fresh fruits and fresh vegetables. But as a doctor, I couldn't prescribe any of those things. These experiences began a shift in my perspective on my work. I could help treat the immediate issue that brought a patient to the office, but when that illness was being impacted by all of those things outside of the office, I quickly learned that I could not cure the disease. These structural factors are not going to go away overnight, but they motivated me to start thinking, how can we do better? If we're going to build bridges to success and help Pennsylvanians live a healthier life, we must tackle the circumstances that caused or perpetuate their challenges to begin with. Those social and environmental factors, like the health impacts of being uninsured or underinsured, living unhoused, regularly not having enough to eat, or difficulty accessing fresh, healthy foods, or going without the routine care, like vaccinations, that is necessary to stay healthy and identify and address health issues early in the course of a disease. Together, all of us, we must commit to looking upstream, to understand the cause of these challenges and work to support prevention and intervention strategies that can overcome disparities and structural barriers to good health and a vibrant, enriching life for all Pennsylvanians. A healthy Pennsylvania is essential to the bright and thriving economic future of our Commonwealth that Governor Shapiro is building. And as you know, we are 2 years into the Shapiro administration with a governor focusing on GSD. Now, do I have to tell anybody in this room? If you don't know, ask your neighbor what GSD stands for. And I'd like to share some of the stuff that DHS has gotten done. We finished the all-hands-on-deck marathon that was the Medicaid unwinding on time and under budget with the 5th lowest procedural termination rate in the United States. We are really proud of that. Last summer, we launched our inaugural Sunbucks program in about 6 months. That was all the time we had, feeding 1.2 million children during those summer months when school is out. We are leveraging technology to improve customer service and client outcomes. We have a new Compass interface that's delivered a more user-friendly self-service option for Pennsylvanians to apply for and manage their benefits. We've increased automated renewals for Medicaid recipients, resulting in more stable health coverage, leading to thousands of dollars of savings in printing and mailing costs, and hundreds of thousands of dollars saved in caseworker administrative time. Successfully implemented electronic health records at our 6 state hospitals. We did not have electronic medical records in our state hospitals. That has had an incredibly negative impact on recruiting and retention of employees, completely understandably, right? So now they are online. Our Office of Mental Health and Substance Abuse Services provided 100% of the project management for this particular project in 6 facilities. Just think about that. And according to our product vendor, we are the largest state implementation that has been completed on budget and on time. We have eliminated our provider enrollment backlog in the Promise system, and Promise is the technical backbone of our Medicaid system, and we're in the middle of a massive modernization of that system, which will make it easier for everybody to use and make it easier for us to update it over time. Our agency was recommended for the National Telecommunications and Information Administration Digital Equity Grant. And I have to underline the word recommendation. We got this just a couple weeks before the administration changed. If it's funded, it will bring nearly $11 million of federal funds to the Commonwealth to improve internet access, digital literacy, and access to telehealth in the 10 most rural counties in Pennsylvania where broadband adoption rates are the lowest and healthcare needs are the most acute. We remain hopeful that the Trump administration will allow this grant to be funded. We have transformed our system for supporting children and youth with complex needs, so complex that they often ended up in hospital emergency departments for weeks at a time with no place to go. We have provided technical assistance to local planning teams to support over 230 youth with complex needs and their families. But just as importantly as the work in the now, in the today, we have, with a huge group of stakeholders from across the Commonwealth, developed and now published the Blueprint Report, which is our roadmap built in collaboration with multiple partners to create the infrastructure to support these youth and continue these discussions to development and implement system-changing recommendations, which many of you in this room have had firsthand experience with and know are desperately needed. And as part of that work, we launched our first annual Pediatric Capacity Building Institute in 2024. This brought 30 people together from across the state over 9 months for learning sessions. They were in different levels of state government, county government, and local governments, hospitals, providers, to work together, to get to know one another, to understand how they could collaborate together more easily. It was met with wild success, and we're actually increasing the size of the Institute for 2025. And I think the day we opened applications, like, we had double or triple the number we could take in about an hour. So that was a good measure of success. We launched the Women's Health Services Program Grant, which now funds 6 regional leads who are providing a range of services that can include nutritional support and education, mental health and emotional support services, safe and stable housing, pregnancy and parenting education, and transportation services, menstrual hygiene products, and much, much more. Our Office of Developmental Programs, with Governor Shapiro's leadership, has initiated the multi-year program growth strategy, which will end the emergency waiting list for adults with intellectual disabilities and autism, a list that has existed for decades. We continue to build out our Community Health Choices program, with the first reprocurement of that program taking place during 2024. We have focused on enhanced quality measures and programs, and we're getting results, with an overall 5% reduction in stroke, and one of our managed care organizations had a 33% reduction in falls through their Women's Health Initiative. 33%, folks, that is really impactful. We have received from the Center for Medicaid and Medicare and Medicaid Services approval of the Keystones of Health 1115 demonstration waiver. This waiver, yeah, you can applaud for that. This waiver creates an opportunity for the Department of Human Services to design and evaluate foundational new programs to address the social determinants of health. And we look forward to the next steps. There's still a very big next step, which is the 2025-2026 budget process. So we'll hear more about that after the governor's address next week. And PA Navigate has launched. All right, who knows what PA Navigate is? See some hands? Okay, good. For those of you who did not raise your hand, I want you to go to pa-navigate.com, pa-navigate.com. PA Navigate is our closed-loop referral system for health and social care services across the Commonwealth. Anyone can go on there, type in their zip code, look up whatever services they need, and get lists of services. But when fully implemented, physicians in their offices will be able to, just like they send a prescription to a pharmacy for a medication, on the next page they can send a referral for a patient to a food bank in their community, or a community-based organization that can help them enroll in the services that they need or qualify for. And because it's closed loop, that social services agency will be able then to communicate back to the medical team caring for their patient that they saw the patient and here's what they did. This is game-changing. It's something I dreamed of having as a doctor, something I dreamed of having as a county commissioner, and we finally have it up and running. And it's just building out, getting bigger and bigger every single day. We have many, many plans for the future, and I didn't even tell you all the things we've gotten done. But I do want to acknowledge that the future looks a bit uncertain today. When the Affordable Care Act was passed back in 2010, Pennsylvania's uninsured rate was 10%. In 2023, that number was down to 5.4%, nearly half of where it was before the Affordable Care Act. Because of Pennsylvania's work to implement Medicaid expansion and embrace a robust individual market overseen by Commissioner Mike Humphreys and our colleagues at the Pennsylvania Insurance Department, and made accessible to Pennsylvanians by Penny and Devin Trolley and her team. And I know she's going to be speaking, I think, maybe after me. And I want you to know how closely DHS and PID and Penny work together. We are true partners because this is a continuum of access to insurance, from Medicaid to Medicaid expansion to Penny. Today in Pennsylvania, our Medicaid program covers over 2.9 million Pennsylvanians. This is 23% of Pennsylvania's population, folks, 23%. And about 750,000 Pennsylvanians are covered through Medicaid expansion. 750,000. And I want you to understand, since you're not like an ACA nerd like I am, that the expansion population, that 750,000 people, don't make enough money to qualify for subsidies to buy health insurance on Penny. This is how the ACA was built. There was regular Medicaid, traditional Medicaid. There was the expansion population. And then once you got past the expansion population, about 133% of the federal poverty level, then you could go into Penny. And so the subsidies to help people, lower income people, pay for premiums on pennies don't start until 133%. So if anything happens to Medicaid expansion, everybody between 100% of the federal poverty level and 133% are going to be in a hole, frankly, with no easy way to get out of it. As of 2023, hospital uncompensated care is 27.7% less than it was prior to Medicaid expansion, even though healthcare costs have increased during this time. So if you want to learn more about our Medicaid program, our SNAP program, what the data looks like, where people live, what their ages are, and things like that, you can go to dhs.pa.gov/data, D-A-T-A. You can see what county populations look like. There's a wealth of information there. But I also want you to know that regardless of what is swirling around us, Governor Shapiro, this administration, myself, and my team, we are laser focused on the everyday issues facing Pennsylvanians. Health inequity, costs of care, access to and quality of care in all communities, rural, suburban, urban, and others. Some examples of how this focus is leading to results. To address maternal mortality, we've expanded access to doula care in our Medicaid program, invested in partners who provide outreach, care, and support to pregnant and parenting people in all communities. And we're finalizing development of a maternal health strategic plan that will chart a course for this work moving forward. To support health providers doing innovative, compassionate work to bring care to unhoused people where they live, we changed our Medicaid program to allow certain Medicaid-enrolled providers to bill for services that are rendered outside of a traditional brick-and-mortar clinical setting. This practice, which is known as street medicine, helps people who are unhoused and helps them, who are unhoused and face the serious life-threatening risks to treatable or preventable conditions, get care sooner, and it builds trust that encourages more regular care. And I know Representative Dan Frankel is in this room. I saw him when I walked in. I do just want to give him a shout out. He has been committed to street medicine for years. Thank you, Representative Frankel. What's important about this is that street medicine's not new, right? People have been going out as volunteers, physicians, nurses, medical students, others, for years. But now they can get reimbursed for it. And we all know that The things we pay for are the things that we value. And so what we are seeing across the Commonwealth is that hospital systems are either expanding their existing street medicine programs or they're starting them, because now it's a service that they can get reimbursed for. And this care for unhoused individuals where they are is essential. And it is that first step to get folks in for treatment that hopefully will lead to stabilization in their lives. So we're extremely excited about this. Pennsylvania was one of the first states to incorporate this into their Medicaid program, and following us were a couple of other states, and everyone's been so successful that as of October of 2023, CMS went ahead and made this a nationwide opportunity. So we were real leaders in this space. We also worked closely with Senator Pittman to allocate $10 million in the 2024-2025 budget to help stabilize rural hospitals, an investment of state funds that enabled the Department of Human Services to draw federal matching funds for a total of $36.7 million to support our rural hospitals. And we continue to explore and develop strategies to support rural health and rural hospitals and providers to promote sustainable, that's the key, it's got to be sustainable access to high-quality health care in all of our rural communities. And we continue to develop ways to use our Medicaid program to address health-related social needs that adversely affect a person's health, quality of life, and ability to thrive in work, education, and their community. Each of these initiatives are driving solutions for current problems, but we know there's always a risk of greater challenges. I strongly urge our partners in the federal government not to lose sight of the progress that came because of what we've been able to do over the last 15 years. Failing to do so and dismantling that work only risks further instability for healthcare providers, our nonprofit partners who support their work, and most importantly for all of us and the people that we serve. It jeopardizes the health and well-being of the people that this system was built to make sure had some stability and opportunity in their lives. It will impact every single one of us in different ways. Our commitment at the Department of Human Services is to the health, safety, and success of Pennsylvanians in all communities. We accomplish these goals by treating our most urgent problems and preventing further harm. Pennsylvania is evidence that we can do that together, and we must continue to build on this progress as we look forward. I hope each of you will join me on this journey and be part of it. It is going to take all of us working together in this moment to not lose the progress that we've made, to keep this momentum going. So thank you. I know you do hard work every single day. I hope we've been able to make that work just a tiny bit easier. And I hope that you see in some of the things that are underway at DHS that if it's still not that much easier, maybe it will be a few months or a year or so from now. But we do this work in partnership. I wouldn't be here without all of you, and I hope that you know that I'm always here for you. And I look forward to continuing to work together in the years to come. Thank you so much.
Thank you so much, Dr. Arkush, and I can vouch for the data page. That is a tremendous resource for journalists. I'd like to invite the panelists up for our first panel. It is Addressing Challenges with Pennsylvania's Healthcare Workforce. This panel will be led by our moderator, Dr. Linda Thomas-Hemak. She's the president and CEO of the Wright Center for Community Health and Graduate Medical Education.
Chairman, it's nice to meet you. Very nice to meet you. Insider perspective. Representative Conroy.
Hey, good, how are you?
Nice to see you. So, good morning, everybody. I'm so excited to be here with you today. I probably haven't moderated a panel in 20 years. So, but you know, one of the things that I really believe in, I'm a primary care doctor. I'm a public health enthusiast. I went to big academic medical centers, and I returned home. I practice in a small borough of about 1,200 people, and I take care of multi-generational families. And one thing that you learn in those small boroughs is that there's power in working together, and sometimes that requires you to lean in and do things that you've never done before. So I'm here. It's such an honor to be here. We have an incredible panel. I met them once in a Zoom call, okay? And I think they understand the rules of engagement, which is they just bring this wealth of perspective, very different lenses about the hot topic of workforce development and how it's impacting Pennsylvania healthcare, which is really in the epicenter of a national crisis with healthcare workforce. We all see it in the news, right? The great resignations, people are burnt out, and very complex conversations about why is that. So we have just an incredible panel for you today. You can read about their amazing backgrounds. I do want to give them a minute after I finish my story about so why did I lean in, right? Other than, I went to faith-based schools and I'm into stewardship and everybody has to do their part and collective impact and all of that. And one of the reasons I leaned in is because I have the great privilege of working for what we call a GIME SNC. That's a Graduate Medical Education Safety Net Consortium. And what that is you take all the federal and state resources and you put it all together, whether it has to do with taking care of the people or generating the workforce, okay, because we generate workforce to take care of the people, right? So it's all kind of the same thing. And when you take on the responsibility of leading any healthcare delivery service or any nonprofit, and you find yourself in the emerging position of becoming its CEO, there's a responsibility there to be sure that it thrives, to continue as the community asset that it is, to take care of the community and the patients and families long after you pass through and you move on. And in that space, you've got to have a workforce development strategy. So this is a really important conversation. And I'm going to shout out, because she was kind enough to shout out Chairman Frankel and all of his work in street medicine, I'm going to shout out Valerie Arkush. Because I have to tell you, I think you're one of the most significant public health thought leaders in government. And I know she's a physician, but really there's no conflict of interest because I don't know her that well. But I have to tell you that when I was streaming through a bunch of federal announcements and I saw the approval of the CMS for the Medicaid waiver that I understand may now be at risk, okay? The delivery of a Pennsylvania Medicaid waiver to address the complexities of socioeconomic determinants of health focused on children, pregnant women, homeless, people struggling with substance abuse, and people in prison systems to ensure that they get adequate access to Pennsylvania Medicaid and the resources they need at some of the most vulnerable times in their lives is brilliant. It's brilliant. I don't know if you've read it. Every time I look at it, I get a lot more from it. I'm very interested, that's why I came. I'm very interested in connecting workforce development and strategies to the success of that Medicaid waiver, the keystone of health. So that's why I'm here. And now that was probably too much for a moderator, sorry, I'll be quiet. But anyway, rules of engagement, everybody's got to speak, and I am going to let you know that we're going to pioneer something together for City and State today, which is called Slido. Okay, Slido is a new conference technology that gives you the ability, when they give you the code about 30 or 40 minutes in, you can type the burning platform question that has come to your mind. And by consensus, those questions are going to guide my further questions, and we want to have time for that in the last 15 minutes or so. So we will know Slido's coming when I ask our panelists, all of the questions, and then you'll see up there a QR code, and we'll all go on this journey together, and we'll go down in history as being the conference that actually pioneered Slido for City and State. Okay? Okay. So here we go. Brief introduction, just your name, the pronunciation of it, and the time, and your title.
Oh, great. Good morning, everyone. My name is Yulia Van. I'm the Public Health Director in Allegheny County, and it's an honor for me to be here with you and be part of this conversation.
Good morning, Nicole Stallings, President and CEO of the Hospital and Health System Association of Pennsylvania.
Good morning, everyone. Zach Schamberg, President and CEO of the Pennsylvania Healthcare Association and Chair of the Philadelphia Eagles Super Bowl Committee. And just to be clear, I know Chairman Frankel is probably a Steelers fan, so I've already put myself on a lower level.
I'm Dan LaValle. I am from Pittsburgh as well. We were rooting for the Birds. This is going to be a nice one. I'm a Senior Director of Social Impact at UPMC Health Plan, and lovely to be here.
Everybody, State Representative Tara Khan from Philadelphia.
Good morning. I'm Representative Dan Frankel. I'm from Allegheny County, and I chair the Pennsylvania House Health Committee. And I do root for Philadelphia teams as long as it's not at the expense of the Steelers.
So thank you very much. There's a nice introduction. I think you all have a copy of it. I want to thank Amy Weschler and Jen Walsh for making sure that that framework and perspective is here. Obviously, there's healthcare crises going on in our nation, going on in our local communities, but what we're really here to talk about is the state level of that phenomenon that's pretty complex, and the lens that each of you brings. So we're going to start with some questions. I will kind of direct them and coach them to a panel, or a panel member, but I know from meeting you one time that you'll have burning additional comments to make, and I just want to remind everybody that we do want to get through 4 questions, okay? So rules of engagement. And, if the audience looks restless, it's probably for us to move on in the questions, okay? So my first question, I'm going to ask to the Honorable Chairman of the Pennsylvania House Health Committee. Thank you for your service, Chairman Frankel. Can you share with us the urgent policy reforms, things that might keep you up at night, initiatives, and maybe some hopeful prospects of what the Commonwealth is prioritizing to address healthcare workforce shortages, to reassure everybody and bring us to a more sustainable future where we're not talking about burnout and maybe talking about joy?
Thank you. I mean, this is obviously something that is, I think, impacting all our healthcare systems across the state of Pennsylvania, and I think it has to be a multi-pronged approach. Clearly, and you'll hear from my colleagues who are on the provider side, I think the urgency of the need to address this. We have opportunities to look at different types of tools that we've seen through the pandemic, the expansion of telemedicine, the ability to take a look at scope of practice issues. I mean, I think these are things that we need to be talking about. They're difficult, challenging conversations that over my years of being in the legislature, when you talk about scope of practice, it creates all kinds of chaos in trying to deal with it. But we've got to take a look at it. For instance, when we look at the behavioral health sector, we know that there is a shortage of psychiatrists out there with prescriptive authority. I put out legislation to, in a small way, address that by providing opportunities for psychologists with additional educational requirements to be able to obtain, prescriptive authority. We have, nurse practitioners, primary care providers who may not have the expertise in behavioral health, and they have the opportunity to prescribe. So we ought to be able in the behavioral sector, as one example, a way to increase access to folks to be able to do this. And there are other areas. I mean, there's so much resistance to talking about these sorts of issues, and I'm sure I've got many folks on many different sides of this. But other states clearly have moved forward with expanding scope to be able to, in a safe way, the sky didn't fall down, people weren't harmed, and that we ought to here in Pennsylvania be able to use those opportunities. We've also done some things, for instance, expanding the ability of nurses' aides to provide medications to folks in nursing homes. It's a small thing again, but again provides the opportunity to free up nurses in those facilities, and also perhaps provide a career path for folks at the lower end and the entry level of this profession to be able to advance and gain and create kind of that pipeline that we need to get additional nurses and so forth. We have programs in my community in Pittsburgh. I have formerly on the board of the Jewish Healthcare Foundation. They have an initiative called Health Career Futures, which talks about trying at a younger age in high school to talk to students, to give them opportunities to look at careers broadly in the healthcare field so that we have opportunities. We're looking at a piece of legislation with my colleague, Representative Rapp, my co-chair. People, think that we're on total different sides of every issue, but we actually work collaboratively, and we're going to be putting forward a piece of legislation next year, next couple of weeks, I think, on a loan forgiveness program for folks working in healthcare professions in rural areas, which is a true crisis that we have to deal with. We also passed legislation last year to bolster the Rural Healthcare Redesign Center. That has been a real success story in being able to keep hospitals that participate in that program in business, as opposed to what we've seen throughout rural Pennsylvania, where hospitals have been closed or purchased. We got, between the large healthcare systems and private equity, a real crisis. But this is a tool to be able to preserve access in those communities as well. So I think we have many opportunities, I think, to work together to address this issue. It's not a simple answer. So.
Yep. Thank you so much, Chairman. And I will say that on the moderator introductory call, one of the most exciting things is the tone by which you brought forth the very controversial issues like scope of practice, and begin to talk to them, talk about transforming those conversations and transforming the narrative beyond what has been centered on the professional stakeholders rather than on the collective responsibility to the needs of the public. And those conversations really do need to evolve, and perhaps some action in the dynamics of teaching people teaming. Because I practice in a rural borough, and I am lifeline dependent on my nurse practitioners, and they don't want to be a doctor, and I don't want to be a nurse practitioner. And we all have mutual respect for each other. So transforming the conversations and the courage to open up Pandora's box, but to invite it with like an equanimity and a calmness and a call to public good. I have a tremendous amount of respect for you, and thank you so much. So Representative Khan, as a nurse practitioner, fearless as you are, can you kind of add some perspective about what's inspiring you in policy and emerging solution actions in Pennsylvania government?
Sure. So thank you. Yes, I mentioned I'm a nurse practitioner. Also, just recently finished my PhD at Penn, University of Pennsylvania, for nursing research. So researcher. And actually, before I get into that, I just want to give a shout out to some of my colleagues here, Representative Tim Twardzik, Representative Arvind Venkat, and any other legislators here. Just give a shout out to. Is that Joe Webster, Representative Joe Webster, and of course Chair Dan Frankel. It's a privilege to serve with you all. So I want to talk about some of the things that I think are going to be helpful to increase our access to care, keep our workforce strong. The first one is our safe staffing. It's a bill that really was not able to get moved. Chair Frankel moved this bill. It's something that we know if we had the same staffing standards as we had in California, every day we'd save 3 lives. And that's research that is consistent, not just one study, but several studies over a period of 20 years. So that's something that we're fighting for here in Pennsylvania. Again, if we had the same staffing standards, 3 lives a day would be saved. It's also important for, I think, our nurses to stay at the workforce, stay at the bedside. We still have the same supply of nurses that are going into nursing school. And I can tell you, as a nurse who worked at the bedside, you don't want to work at home care when you get out of nursing school. You want to go where the action is. You want to be at the hospitals. And so nurses are struggling in the hospitals. The problem is they're getting burnt out because they're having to do the job of two other providers, two other nurses. And they can't sustain that. And so they leave the bedside. So we have to make sure that we are keeping things safe at the bedside. Safe staffing centers will do that. We also have as Chair Frankel talked about, the full practice authority for our nurse practitioners. This is a bill that we know, again, not one study, but many studies, would actually increase quality of care and increase the access to care for patients all across Pennsylvania. I'm proud to have introduced two bills that would actually help, again, with the workforce. One is our nursing faculty. Unfortunately, we have actually, there's an issue because a lot of our nurse teachers are getting older, they're retiring, and we don't have that new crop of nurses coming up. So this actually would model a Maryland program that would give $10,000 a year for these nursing faculty students, and they would be able to get that for the time that they're in school, for the 4 or 5 years that they're in school. The other bill is for our preceptors, because we have a lot of preceptors. We have a shortage. A lot of times we're trying to get hours for these nurses, also for physicians as well that are trying to get clinical hours. So this would give $1,000 to those providers to be preceptors. So just some of the many things. But again, as Chair Frankel said, we have to do these on a bipartisan manner. Very proud that as a co-prime sponsor, been working with Republicans to introduce these bills. The first two, the Safe Staffing and the Full Practice Authority. Thank you.
Thank you so much. And I think from the perspective of a practicing physician, nothing is more important than safe staffing at the bedside, in the room, right? Because that's where it gets compromised and it really has devastating impact if it's not. But the second thing I want to call out about workforce development is that innovation that, I don't know, it seems like $1,000, just to take on and be a faculty supervisor. That has huge implications because even on the medical side right now, there's a focus on debt coming out of medical school and everybody's strapped for access to clinical learning environments. And so people are selling rotations and a lot of times the students are at risk for that, putting it on the back of their tuition pack. And so those are the game-changing activities, I think, that can come in and change the conversation to get more logical and disciplined and rational and impactful. So we're going to move on.
Can I just jump in real quick?
Please.
I think that was in the rules, and tell me if I'm going
Absolutely.
beyond the rules.
Go right ahead.
First of all, I want to thank the chairman for his leadership.
I was going to call you anyway now.
Oh, well, perfect. There we go.
He set you up.
I want to thank the chairman for his leadership in advancing the legislation that created that med tech in nursing homes. And that really does, as the chairman noted, start us on a bigger and better career path in long-term care. When I hear the word innovation, immediately things come to mind because I think what Representative Khan said is so important, that at the end of the day, whether we like it or not, we are facing a healthcare shortage in Pennsylvania. And I'm reminded of a study that was conducted in 2022. It was a national study of nurses. And what it said was that at that time, 1 in 4 nurses, 1 in 4, were going to leave the profession in the next 5 years. And at that time, the median age of a nurse throughout the country was 46 years old. We are working with, or trying to work within, a finite workforce pool. And I represent nursing homes, personal care homes, and assisted living communities, that part of the healthcare continuum. And inevitably, our providers are fighting over the same workers that hospitals and the acute care space are, that home care agencies are, that physicians' offices are. If there's not a workforce crisis in long-term care, it means that there's a workforce crisis in the acute care space, or vice versa. So we have to be innovative. We have to grow the workforce pool. And I'm reminded of a program that was started at the height of the pandemic, the temporary nurse aid program for nursing homes. This allowed ordinary Pennsylvanians to take an 8-hour online training class, to come into a nursing home to get hands-on training, and then get hired as a temporary nurse aide. We were then able to pass legislation that converted those temporary nurse aides into full-time CNAs. And we grew our workforce by thousands of workers. But when the pandemic ended, The temporary nurse aid program ended as well. Why? Those are the types of innovative solutions that we should be looking to grow our workforce pool. I would also add, given that we were talking about Washington, D.C. a little bit earlier, and who knows what's going to happen in Washington, D.C. Nationally, 28% of our long-term care workforce is comprised of immigrant workers to this country. There are states like Arizona and Massachusetts and Minnesota that are prioritizing that group of workers with grant programs and training programs. I believe Pennsylvania can do the same. The representatives to my right have been innovative. They've thought outside the box. We know we have colleagues in the House and the Senate who have done the same thing. We need to continue to do that because at the end of the day, we have to grow that workforce pool. Thanks.
So Zach, I just want to say, and I'm going to call on you in a minute, I just want to say that you read the question without knowing the question because we were going to ask you and we were going to ask Nicole too as well to comment on what programs have you seen work, and so what can we feed back to Pennsylvania legislation to bring forward as a priority. I do want to shout out to you because we understand that the healthcare crisis in your long-term care world is actually force multiplied because of the aging of our population. So you're really in the eye of the storm right now, and we really want to just bring forth, let's prioritize care of the vulnerable elderly, given the fact that Pennsylvania has more than a national percentage share of the aging population and real issues with vulnerable elderly. So I just wanted to validate and thank you because that was your question.
Well, and just and,
so it's all good.
And one more note, and then I'll turn to my colleagues. But I'm also reminded, in your words, of a Center for Rural Pennsylvania study that was published in December that focused on dementia and Alzheimer's, especially in rural areas of Pennsylvania. And by 2040, the number of Pennsylvanians that are diagnosed with Alzheimer's or dementia will increase by 133,000. And the report published in December said we are ill-equipped to care for that population. So it's not just our aging population. It is our aging population that will have those specialized needs that we need to be ready for, and we're certainly committed to working with our elected officials to ensure that we'll be able to care for them.
Yeah, one more shout out for the name of that program during COVID, temporary, that gave you some reprieve.
Temporary nurse aid.
Temporary nurse aid, program that works, so we should keep our eye on it. So Nicole, please, I mean, we, just as much as I worry about my patients in nursing homes, we are really vicariously distressed by the distress of our hospitals in northeastern Pennsylvania. I've seen 3 in my 25-year career close, critical access places, and I'm very worried about the residual ones. So, what are your thoughts in terms of not only the challenges, but things that you've seen work that you'd like us all collectively supporting on behalf of our hospitals?
Sure, and we share that concern. At the end of the day, I think we all have the goal of ensuring access to care across the Commonwealth. And when we think about access, we know that workforce is a challenge faced by every hospital, in every community across our state. I do have to just say, while I agree with most of the policies that were mentioned by the representative and the chairman, our position's pretty well known on prescriptive mandated ratios and what the impact will be to our state. California, I believe, is a failed experiment with respect to workforce shortages they still have, wait times that they still have, and we also unfortunately can look in our own backyards and look at what the impact, which I think I would characterize as devastating to our nursing home industry with respect to the staffing requirements that have been placed that are impacting our ability to move patients through the continuum. And so I choose instead to focus on where we know we can address some of those solutions, grow our pipeline. All of the other bills that were mentioned, we are strongly supportive of. What I'm incredibly proud of is the way in which our hospitals over the past several years have worked to implement strategies to grow their workforce. Virtually every hospital has increased base pay, offering bonuses for retention and tuition assistance. Pay in our hospitals has gone up 39% in recent years. Almost 40% of our hospitals offer child care. Only 6% of employers nationally offer childcare. And the thing that's the most exciting, I believe, are pathways. I'm recalling an article that I read in Health Affairs. It started off with the word imagine. Imagine you enter a career and with only a high school degree, and you are able to double your salary in that same job. And also imagine that you're learning in-demand skills for the future workforce. And that's what's happening in our hospitals right now. I know Dan can speak to some of the work that's happening locally in Allegheny County, but our hospitals are creating pathways. And you've seen it on social media, the badge of that very first job in the hospital, and then where they are now, be it an RN, a nurse practitioner, a physician, a hospital CEO. So we can grow the middle class within our hospital jobs, entry level and up. Those are the things I'm excited about that I look to scale.
I really appreciate that. And what I'm going to do is I'm going to go for time here. I'm going to combine our final two questions. But I guess my feedback is I really appreciate the diverse perspectives. And I think, the answers are going to be in the sweet spot. And maybe we can move beyond the jurisdictional issues, because the quickest way to find out what the children shall be is probably just to dream map with them and give them their choice rather than what the system is imposing or brokering for. So I think, school-based health centers, those kind of things where we're recruiting for our future staff of the hospitals, our future physicians, our future nurse practitioners. And, so we have a little motto that's, you recruit from the community to retain into the community to restore from the community. So when I'm in the room as a pediatrician, I'm looking in the eyes and I'm thinking, this is me role modeling to this child who may have never imagined it, want to be a doctor. Right? I mean, it's very powerful. So
Can't be what you don't see.
Yeah,
So.
can't be what you don't see. Yeah, can't be what you don't see. So we will move on to the significance that you actually highlighted in Pittsburgh, where partnerships are flourishing between the county and the academic institutions. And I'm going to call forth Dan and my friend Yulia, which is just such a beautiful name. It must have a powerful meaning. But let's just talk a little bit about how to connect some of the thriving partnerships to the work of being led by Dr. Arkush and the Medicaid waiver, and to the needs of the hospitals, and also to the front and center of the conversations with our legislators. So maybe we can pull that all together, just spotlighting some of your collaborative work at Allegheny County, and then also particularly with your job, finding the people and bringing them in for that first badge, right?
Yes.
For careers with economic mobility.
Awesome. Well, I hail from Mr. Rogers' neighborhood, as Chairman Frankel does as well. So it is a beautiful day in the neighborhood to be here. We love it. I think for me, our journey into workforce, we started a program called Pathways to Work. We love that word. Began in the pandemic. And of course, we're the UPMC is the largest employer in the Commonwealth. We also have over 600,000 people on Medicaid. And at a time when we all know 1 in 3 of our neighbors were filing jobless claims, but we still needed to have people in homes and hospitals care for individuals that were sick. And we needed to do better. We need to show up, in certain communities to help bring some of these careers and bring a team. So we have a team, we call them Dream Makers. They've been with us for 4 years. They are early in their career recruiters, and some of them have moved on as well on a pathway. They come with me anywhere, anytime, whether it's 1 person or 5,000, to help navigate UPMC and find life-changing careers. And I think, for me, I remember I clicked like a night shift when I first applied for UPMC. Immediately rejected. I didn't know what the heck happened, just because I did something a little bit wrong. But I had someone I could call. We want to make sure that everybody, especially people with a barrier to work, have that. My dear friend, I was hoping she could come. She's not with us today, but one of our first hires into Pathways to Work. We've hired almost 9,000 people off Medicaid over the past 4 years. One of our first, her name is Marquesha. She would tell her story as this, and I want to give you this just see what can be. She was 8 months pregnant, working retail, customer service role, working on her GED in 2020, and lower wage jobs significantly. But because we had a team, she's looking to get out but had no hope. Because she was able to find somebody, one of our recruiters, they were able to see that she had good customer service skills. And, like all of us, even me, even when I call, to think about something on the health plan, it's not always a nice conversation, so you need to have people that can give hope and have just deal with challenging situations. And what her job has been is to call seniors in high rise, especially during the pandemic, make sure they had their meds, which there's no more important job at the health plan than that. and she has been promoted a number of times and wants to be a pharmacist someday. And I think because she saw it, and I know that's what she would say. And I think for us, it's all about, of course, having that team. We needed to have that team, that we can go out anywhere, anytime. But I think secondly, what's meant a great deal to us is partnerships with the workforce system. With labor and industry, our local workforce investment board is Partner for Work. They've been incredible. We are going to be the leader in apprenticeships in healthcare in this country within a couple of years. And I think a lot of that is because we're willing to take a chance. We've had a facilities maintenance, as Zach was talking. Average age of our facilities leaders was 68. So we needed to make sure we were getting into high schools and showing that there could be a great career there and do it. And we've been able to do that with apprenticeships. And that is incredible. And I think people think of apprenticeships only as a trades or only in certain areas. And we can do that here. We're working on it for nursing soon, as well. And I think I would close with just to add, Secretary Kush, just an incredible individual, obviously, and what they've done is illustrated clearly with one of our programs that we have that's actually about to start out here in Harrisburg. We call it Freedom House. It's a call on the 1960s program that began emergency medical service in this country. I didn't even know that when this started. And it's a beautiful thing because it took people who were deemed unemployable, which is wild to me, that phrase, in the 60s, taught them how to be EMTs, and then cities across the country adopted this. We revamped this program a couple years ago because we realized we needed to change how we did training, obviously paying people in trainings, trauma-informed, doing it with all of our partners. But the first class, we had people who came that were hungry, that did not have food that day. So we had to put a food distribution in the class. And we do that to this day after 18 classes. There were a number of single moms who brought their kids, there. I'm a father, I have an 8 and 3-year-old, So obviously I see that. What were we gonna do? Saying you can't be in this class because you had a childcare need? No, some of the children, came to the class. On those days when childcare, Heather, don't tell our lawyers, I might get in trouble for that. But, but what were we, we got to stand up and do that differently, and help a little bit. So I feel like we're at a time, and that connects to so much of what the Secretary and DHS is doing with helping people coming out of reentry and helping people with housing supports, and how we can have life-changing careers. So I feel it very deeply. My great-grandfather came to this country with an 8th grade education. It was in an apprenticeship as a baker. And then we had a family bakery for 60 years that he ran, and they hired people coming out of incarceration in Pittsburgh. So to me, it's personal, and I love it, and we're going to keep moving forward.
You're awesome. And
thank you.
Clearly, I just want to top it, though. Okay, my grandfather was.
Can I just say, I'll have what Dan's having.
So my grandfather was the Galliano and the chicken man in the Italian immigrant community, but here's the one up on you, okay? I live in German, Pennsylvania, which is the borough of 1200 where I practice, and it happens to be the birthplace of first aid. So awesome, right next door to the city of Carbondale, which happens to be truly the birthplace of Robert Wood Johnson. So all those little details are going to be what we bring forward. And, I do want to give a shout out for America 250. America's going to be 250 years old, and we have an opportunity in Pennsylvania to win the state celebratory award because of Pennsylvania America 250. So everybody get involved and look at the Liberty trees and the Liberty bells that are coming, and it's going to be awesome. But I think your message is, like Valerie Akush said, this is all hands on deck. And every Pennsylvanian is important, and they all have contributions to make, regardless of varying capacity, intelligence, socioeconomic backgrounds, and experience. So we need them to come forth with their contributions. But Yulia, you want to talk about partnerships, things that have happened in Allegheny County? Certainly a role model place for public health, I believe. So.
Yeah, thank you. So first of all, Dan, the stories were just so inspirational, and it's just so awesome to see the dynamic and the stories that are being shared here at the table. I feel really honored to be able to sit here at the table and represent the voice of public health. I feel like it's important to mention the fact that public health has very similar, attributes with the healthcare system and the other, systems that are serving our patients in our communities. We're looking at the community as our patient, and a lot of times, workforce is really the makes it or breaks it, for us to protect the communities that we serve. Another point that I wanted to make, just as a general idea, is that we need to find ways in which we can be very flexible in the way that we're funding public health, the way that we're supporting public health, and that we're not only looking at public health when there is a crisis, that we're not only looking at the importance of having public health professionals when it's something that's burning and now we need to call on public health to put the fire out. We have to be able to maintain that continuous spectrum of development and recruitment and retention of these professionals in order for us to be successful. It will not work if every cycle of crisis we have to then go out, spend incredibly resources and energy to recruit the people to come into public health, then train them in order to be successful public health professionals to protect the community. So I just felt like this was just an important thing to mention. Public health also has an incredibly varied public health workforce. We have the nurses, and we have the administrators, and we have the billers, and we have the community health workers, and then we have the people that are working on contracts, and we have the environmental health inspectors, and then we have the practitioners, the doctors, and so on and so forth. So it is such a rich, diverse workforce that needs full attention on so many different levels. So those partnerships that we were just talking about are just so incredible and so important for us to be able to move some of these things along, to fill some of those holes, and to create a culture in which we show our team members that we value them, that we believe in them, that we want them to be successful. I feel like right now, so I'm fairly new to Pennsylvania, but I feel very welcomed here, and it's just been an amazing 6 months. I come from North Carolina. I'm not new to public health. So all of the lessons and experience that I have been able to learn in my local government experience are extremely relevant to the communities that I serve now. So, Pittsburgh and Allegheny County, it is it has such a legacy for institutions of higher education and educational institutions with, CMU and Duquesne University and University of Pittsburgh, 5 other private universities, a community college. So we have that very robust history of education and research and innovation. So building those partnerships and growing those partnerships are incredibly important to me as the health director and the leader of the health department. We have so many different partnerships. I think that Dan already mentioned the Partnerships for Work, where we are part of that through our apprenticeships program for dental assistants. So that's another, we have dentals and dental hygienists. So that is another area that is so difficult to recruit. So trying to build that ladder, early on is important. Going into high schools and having the opportunity with our partners at Pitt to talk to high school students about the opportunity of a career in public health. That is not really something that, when I was in high school, nobody talked to me about public health. Nobody told me about the opportunity to move in that direction. I knew that I wanted to be a doctor. Well, I went to school, I became a doctor, I was a family practitioner, and then I felt like my impact is going to be outside of the office.
So, Yulia, it is really the message that public health can be the unifying force to take all the stakeholders to the conversation of we.
Absolutely.
And that,
yes.
Forums like this, there's power in proximity.
Absolutely.
Right.
I think that in general, public health framework has created just the idea that public health serves as a backbone entity. We're conveners. We are, bringing togethers type of people.
And that the focus of the conversation with public health is every Pennsylvanian.
Yes.
Everyone, yes.
Correct.
So I can see people kind of getting to the edge of their seat. There's so much perspective and gifts and experience to share. But I am going to give you an opportunity before we move to Slido and empower the audience to get all those consensus-driven questions up. I'm just going to give you the opportunity to go around and just in literally like 60 to 120 seconds, just whatever has come up as an urgent priority that you want to give as a gift to the community in terms of something really important. Let's just kind of do a round robin of that. So, Nicole?
Sure. I would say, it's an incredible privilege to represent our hospitals, their safety nets, their community anchors. They're also economic engines. And we know that workforce development is not just about providing access to care. That's certainly why we are prioritizing it. That's our top priority. We have an access agenda, not an advocacy agenda. But it's also about economic development because people want to live where they can access healthcare and services that they need. And we know that healthcare deserts, of which we know we have them in maternal health, behavioral health, and other parts of our Commonwealth, they can very quickly turn into economic deserts as well. And so I think this is a critical conversation, not just for HAP, not just for our hospitals, but for our patients, our communities, and for the Commonwealth.
Yes. Zach?
Yeah, I worry about the infrastructure in Pennsylvania, given our aging demographic. 3 days ago, a nursing home and a personal care home closed, effective immediately in Clarion County. In Clarion County, there were 3 nursing homes. 2 have changed ownership or sold, and 1 is now closed. Given our aging demographics, we have to ask ourselves, are we going to be care for that rising number of Pennsylvanians? If Medicaid reimbursement doesn't keep pace with rising costs, if we don't solve the workforce crises across the state, if we don't improve the regulatory climate or the tort climate, providers will leave, as we saw in the year 2000, 2001, and 2002, and we will see folks and their families travel hundreds of miles out of state just to receive care. We can't let it get to that point, but it's very quickly getting to that point unless we act.
Thank you so much. Let's just back up here so then we can end with Chairman.
Yeah,
Thank
you.
1 to 2 minutes. Thank you.
Yeah, sure. So just to piggyback on what Zach was saying, I think that the aging population is also applicable in workforce. Right now, we have the most dynamic generational diversity in workforce. So thinking about the way that we're recruiting, retaining, and providing workforce development within that dynamic of a variety of generations from baby boomers to Gen X, Gen Z, millennials, thinking about what is important, what is meaningful, what are their expectations and motivations. I think it's incredibly important for us to be successful. Thank you.
Thank you. Dan?
All right, so from my avenue, when I first learned what a workforce investment board was, there's 22 of them, I think, across yeah, right, exactly. And, I realized, I'm like, oh, wow, there's federal funds that can come in here. We can all work together. It kept saying this WIOA. And WIOA's going to bring all this good stuff. And I, for 3 months, thought that was a human being was going to come with all these funds for workforce. But then I learned what it was. But I just realized, though, at that point, that we could, though, there was something special that could happen if we just be vulnerable. Work with our workforce boards as a large employer, many of our other employment and training organizations. There's a chance to build a model for the country here in Pennsylvania, not just for healthcare, but if we just can talk to each other, break down a few barriers and build programs. We've been able to do that. Not all have worked. But we're looking to continue to build the ones like the apprenticeship programs that Dr. Van has and others to do this and move the Commonwealth forward. So,
thank you.
Yep.
Representative Khan.
Thanks. So as a state rep, I'm focused on making sure that we have healthy communities. I also, I represent Philadelphia, but as a state representative, I want to make sure that Pennsylvania is the place that people want to come, they want to work, they want to invest in, they want to retire in, they want to vacation to. And a lot of that is having healthy communities. So I'll say two things. The first one is actually working with Chair Frankel on making sure that in this new administration we're protecting the health care that we have for our community. We actually just floated a co-sponsorship memo today protecting essential health benefits together, also protecting the ability for kids to stay covered under their parents' health care insurance under the age of 26. And there's actually a whole package of other bills that are protecting the ACA. Secondly, too, some legislation that we're looking at. I'm proud to serve on Chair Frankel's old committee appropriations, and a couple of the bills that we're leading, helping to lead, is protecting, first of all, increasing our minimum wage, which there's a very clear line between low minimum wage and poor health outcomes. So raising our minimum wage, which is $7.25.
Yeah.
So imagine trying to live on that. And also I'm working with Rep. Kincaid for universal lunches so that kids in school can have universal lunches. I'm working with Representative Doherty on universal pre-K So getting kids enrolled in pre-K, we know that improves health outcomes, getting a healthy early start. So
Thank
just
you.
some of the things we're working on.
Thank you so much.
Thanks.
Big work, right?
Thank you.
Big work for a brighter future. Chairman Franco.
I'm proud to work with my colleague, Representative Khan, and all these folks who represent vital institutions and organizations that provide that framework for healthcare in Pennsylvania. It's a frightening time as we look around at we don't know what's going to come around the corner. But I think one of the things that I take away from this and listening to Dan and Nicole about trying to create these careers, these apprenticeships, these are important things. But it's not just about providing compensation. It's about providing a future, a career future, and a pathway, a pipeline for folks to choose careers in this field. And we've been working hard at trying to make that easier for folks. One of the things we did do last year that we still can improve upon is eliminating or restricting, limiting restrictive covenants that are imposed on providers that work for healthcare systems in the state of Pennsylvania. It's the only real area. I mean, attorneys don't have it, businesses can't use them anymore. And it creates, I think, maybe counterintuitive, an obstacle for some folks who want to work in Pennsylvania to stay in Pennsylvania, that these types of agreements, restrictive covenants, are imposed on folks. We made progress last year. We limited the way they can be applied to people, but in my view, they ought to be eliminated entirely, and we're going to work towards that to try and create this environment that makes it really desirable to be located here, to be valued here, and to see a future in working in healthcare at every level. So I think we have work to do still. I'm proud of what we've been able to do, and I'm proud to be able to work with all these segments that are represented on this panel today. I think we all, at the end of the day, share the same vision in terms of what the end game is. We may have different pathways, but we work together and try and find agreement. So thank you.
I think that this was an incredible conversation, and I want to thank all of you. I'm leaving here very inspired. In proximity is power. And everybody should expect that when real change is coming, it's going to be painful. And when the painful, environment has a lot of uncertainty, there's probably no better strategy than to stick together. And so if we could just let everybody who lives in Pennsylvania know you are important and we want you to contribute to the victories for communities in the state of Pennsylvania, I think that, that's what should bring us together. And I want to thank city and state for giving us all this opportunity and proximity to have what I've experienced to be a very inspiring panel and dialogue. And now we're going to do something really rapid because Jen Walsh, my friend, is like, you stink. You only have 4 minutes, this and that. And so I'm going to collapse those 4 questions because I read them in that really nice technology that gives you voice by consensus. And I think the punchline is given everything we just talked about, how can the things that we've learned, the lessons we learned from COVID, the application of telehealth, teleeducation, and information technology actually help us to recruit, retain, and inspire the workforce? And does anybody have anything up and coming promising that we want our legislators to know in that space? Certainly the reference, I wrote it down, for the social service exchange, and like as a doctor, I could write a prescription for food. I'm into that. That is a gift to me. So what do you see as some of the most exciting focal points for information technology helping us? Please.
I would note the use of the telenursing, not just telehealth, but telenursing, so that we can ensure that the nurses that are at the bedside are doing the things that we need them to do. We know that this not only has good outcomes for patients, but also drives employee satisfaction for those nurses. So leveraging all of the tools, telehealth, virtual nursing, exploring AI and others. I know Rep. Venkat will talk about AI at some point today as well. I think there's a lot of opportunity.
Yes, thank you so much. Please,
Can I jump in
please.
just a little bit? I think that there's been so many opportunities for telehealth, teleservices, televisits in general in the public health world during COVID. There was so much flexibility, and that's when we saw great collaboration. We saw great results. Our WIC program, for example, through the waivers from the federal government that allowed for us to do a lot of those WIC visits for the Women, Infants, and Children's program, where we provide benefits. That was hugely successful. It was more people participated in the program, more people were getting benefits. It was the customers' satisfaction was incredibly high. So just continuing to advocate for the government entities that receive regulations and kind of rules from the federal government to continue to allow some of that work to be done. I think it's incredibly important. It worked very well during COVID, and we should be able to continue that. Those are some of the lessons that we learned. We shouldn't go backwards moving forward. So it's not just telehealth, it's other teleservices in general. So.
Well, and I think, and bringing it forth with joy instead of resistance in the healthcare industry that previously had a lot of trauma around the way we brought on EMRs, right, top down. But really getting people excited too, AI has the ability to increase the capacity of the workforce for things that really matter, right? And so I think just reassuring people, given all that we need for help, one of the things I tell everybody when they get all banged up about the EHR and the scribing and the artificial intelligence, and don't call it AI, and don't call it this, and call it your administrative assistant, and let it come in the room with you. I just keep reassuring all the primary care doctors, listen, there's no way Watson's replacing us. Okay, we have a relationship with the patients that is valued and treasured as a community asset. Bring it on to help me to be more effective and have a greater capacity to help more people. So the messaging of this isn't to eliminate jobs, because people think automation eliminates jobs. Right? And so to have those conversations up in front. How about, Zach, you have anything?
Yeah, I just want to be a part of this Slido history that you talked up so much at the
pioneering.
start. I would just say that, again, Chairman Frankel and Representative Khan have been supporters, other legislators in the room have been supporters of enacting legislation or furthering regulation that would allow technology to help us with hybrid training for nurse aides and nurses across the state, and that's been so important. But I think what you said is critical. I've had 3 grandparents in the last 16 months spend time in a long-term care facility or community for a number of different reasons. AI and technology will never replace the one-on-one care that they received. In long-term care, this is a person-to-person sector. It's a person-to-person experience. No AI or technology is going to change that. So while that may help with our hiring practices and limiting paperwork, it's not going to help us build the pipeline that we need.
Thank you so much. Anyone?
Sure.
Okay.
It's what we do as Americans. We innovate. And I think during the pandemic, we saw that, I'm a healthcare provider, and we were able to go to telehealth, right, which we didn't have before. And even today, and we're still, I don't know if we've fully codified that here in Pennsylvania. We're still working on it. But as a healthcare provider, you can see patients who maybe are at work or they're taking a few minutes out of work, and now they can see you because, getting to a healthcare provider at, 11 o'clock in the afternoon, what are you doing? You have work during the week. I think we're seeing it for the mental health space. I mean, especially in rural health, for people to get access to healthcare providers, the psychiatrists, psychologists, psychiatric nurse practitioners that never had access before. So I think, and that's, as Chair Frankel said, that's exactly right. It's not a partisan issue. This is not just a legislator versus industry. We got to work together proactively. Again, as you said, we may have to find the sweet spot. Sometimes, we're not going to agree on things, but finding the sweet spot but encouraging innovation, especially with AI and all the opportunities that brings, making sure that we're doing it right and not not going in the wrong direction.
And, allowing and encouraging backbones to organize, because I can shout out to Sherry Reinhardt here, who was the president and CEO through COVID of our Primary Care Association, her successor, Shelley Reiser, where you are. But, with their support and organizing with other health centers, that switch of telehealth was overnight. In the middle of a pandemic, it was overnight. It just went down, right? Because people needed access. So it was amazing how much a crisis can activate innovation that is incubating that you can't see if you're not in the same mind frame. And so I want to thank you for that, because I do think, and the relationship of them with DHS and PADOH, very powerful, right? To help the people who were actually in the trenches. Chairman Frankel, wrapping us up here. IT, information technology. Aren't you so excited?
I am. Look, the pandemic showed us how it works. And I agree with Zach. There's no real replacement for that interpersonal interaction in person with a provider. And obviously, in the long-term care space, that's telehealth is very limited application. On the other hand, I saw it personally. My wife and my daughter are both psychotherapists, and throughout the pandemic, did almost entirely their practices were by telehealth, and they were able to maintain those important relationships with their clients, provide them the behavioral health care that they needed. And in fact, today, while they're both in office sometime, many of their clients still prefer having that telehealth relationship. And, I think it increases access, makes it more convenient for folks. We need to make sure that we maintain it available for us, and maybe even expand it to other areas. One of the things that we're looking at is using it in dentistry. And I know that sounds odd, but there's a way to basically, particularly because when you look in rural areas, access to dentists is like behavioral health problems. They're hard to come by, and at least you can save somebody, driving in from Warren County to Pittsburgh for care, if they can at least be triaged through teledentistry. So there are, I think, innovations that we can continue to make here in this space, while acknowledging that in-person care in many cases is impossible to completely replace. Thank you.
Thank you so much, and thank you so much to the panel for making one of my first moderator experiences not traumatic and actually fun and enlightening. And thanks to all of you, and thank you so much to Angela and all the folks at City and State for gathering us and generating this proximity. Thank you.
As the first panel exits, I'd like to thank them so much, especially Dr. Thomas Hemek for moderating. We are going to have a presentation by Devin Trolley, the Executive Director of Penny, in just a moment.
Great job. Thanks, Lana. That was great. You were great.
I love it. Rob, I think Rob works with you some on my team.
Yes.
That's a priority for us.
I think it's time for you to go.
Oh, thank you. I want to support
That's my card, my cell phone, yeah, it's weird. So you're just okay. So I think the
Hey, how you doing? This is
Excellent.
slideshow. Okay, I'd like to thank the first panel as they exit, and if I'd invite everybody to take their seats again. so that I can welcome to the stage Devin Trolley. She's the Executive Director of Penny, and she's going to make a presentation on the changes that are impacting health coverage in Pennsylvania. So everybody could give a hand and their attention to Devin Trolley.
Don't want to interrupt the picture. Right, good morning, everyone. Great to be here. I know there's a bit of a water coffee break after the last panel. All right, so I'm just going to go ahead and jump in. I'm Devin Trolley, the Executive Director of Penny, PA's official health insurance marketplace. I want to thank City and State PA for having me here today to talk about our record-breaking success and what lies ahead. I know you heard from Dr. Arkush earlier about the coverage picture here in Pennsylvania, and I'm here to talk about Penny and how we fit into that coverage piece of the puzzle. Penny's origin story goes back to 2019, when the General Assembly passed a bipartisan and unanimous law for PA to better meet the coverage needs of the Commonwealth. And now, 5 years later, we find ourselves at a fork in the road. And what happens over the coming months will have significant impacts on the 500,000 Pennsylvanians who are enrolled in health coverage through Penny. But first, some quick background. Penny is the place to get high-quality, affordable health coverage. For anyone who doesn't get coverage through their job or through Medicare or Medicaid or other programs, Penny is the place to start. Many of our enrollees are often small business owners, gig workers, independent contractors, or people working one or more part-time jobs. And they come to Penny for that high-quality, affordable coverage. Now, when I say high quality, it's because every health plan that's offered through Penny from a variety of insurance companies has to meet important consumer protections. That's covering a wide range of medical services, free preventive care, and coverage for pre-existing conditions. And when I say the coverage is affordable, it's because Penny is the only place to get, on the spot, premium tax credits that instantly reduce the cost of coverage. Now, the marketplace has always been a source of these premium tax credits since 2014. But in 2021, the tax credits were expanded to apply to a broader range of incomes and higher levels of tax credit across the board. And what this did is it cut costs in half for Penny enrollees, and it made coverage the most affordable it's been ever. This is $600 million annually in direct premium reductions for Pennsylvania, and the impact is clear. Penny just ended its open enrollment period a couple of weeks ago, and we had record enrollment, 497,000 Pennsylvanians enrolled, nearly 500,000. That's the most Pennsylvanians that have ever been enrolled through the marketplace. It's 14% more than we had last year, and last year was 17% more than the year before. And it's really undeniably due to the fact that the coverage is affordable. This means more Pennsylvanians can see their doctors, fill their prescriptions, and get protected against the extraordinary costs of a medical emergency. Simply, this means more Pennsylvanians have peace of mind. But our goal at Penny is not just to do better than the year before. I told my team we have a lot to celebrate, but we also have a lot to build. And what does that look like? It's continuing to cut into the still 600,000 uninsured Pennsylvanians. It's expanding our on-the-ground outreach, education, and enrollment assistance to every county and PA. And it's developing innovative, first-in-the-nation tools to simplify the complexities of eligibility and enrollment, so we empower our consumers to make the best decisions for themselves and their families. We're excited for what the future holds, to really bring to life the vision of a state-based marketplace that's innovative and tailored to the needs of our friends, family, and neighbors right here in PA. Now, as someone who's worked in the health insurance marketplace program for 15 years, I wish I could stop my presentation here on a high note, record enrollment, and a vision for the future. But I can't, because we have a serious problem ahead of us. That fork in the road I mentioned One path allows us to do what I just talked about, to build on the progress we've made, to continue to bring more and more value to Pennsylvanians every year. The other path reverses a lot of the progress that we've made over the past 5 years. And why is that? Because those enhanced premium tax credits that I mentioned that have made coverage more affordable than ever expire automatically at the end of this year. So what does that look like? It means if Congress does not act in the coming months, 500,000 Pennsylvanians will see significantly higher costs next year. We're talking about 82% premium increases on average, and that's an average, so that means half the people are going to see more than that. We see many communities that are going to experience a doubling of what they pay today. And I'll give a couple of examples in a few minutes about people who will pay 3 or 4 times what they're paying currently for the same coverage. 3/4 of pending enrollees have enrolled since 2021. So that means they have only ever experienced health coverage at these lower costs and don't have a sense of what it would take to be able to afford coverage that's 82% or double. That's hundreds of thousands of Pennsylvanians who said, wow, I can finally afford coverage. It's farmers in Lancaster. It's a small business exterminator company in Erie. It's a mom entrepreneur in Philly. These are all consumers who have told us our stories and how much it's meant to have affordable, high-quality coverage through Penny. And now, in the face of increases, they'll be forced to make difficult decisions, figuring out what other necessities they can cut, if they even can cut them, to try to make room for a much higher health insurance premium. Or they have to go uninsured again. And instead of having health and financial security, they'll bring their families back to a time of uncertainty, risk, and fear of what happens if they have the misfortune of an illness or injury. All Penny enrollees will be impacted by these cost increases, but a few subsets will be increased even more. For example, while urban and rural communities will see the highest number of people impacted, our rural communities will see a higher dollar value lost if the enhanced premium tax credits are not extended. Their costs will double. Another vulnerable group we see are middle-income older Americans, those who are not yet eligible for Medicare. This group is at the highest risk of losing all of the tax credits at an age where medical conditions can and do commonly emerge at any time. This chart shows the cost differences between rural and urban areas. So you can see the darker areas in the center parts of the state that are really going to see higher increases. And here I'll talk about a sample couple from York County. Take a 60-year-old couple making $82,000. Right now, they pay $600 a month for comprehensive coverage. Without the enhanced premium tax credits, their costs will increase to $2,900 a month. That instead of paying 8.5% of their income towards health insurance, they would be paying 44% of their income towards health insurance. Again, 44% towards health insurance premiums alone. I hope we can all agree that is not affordable. Small business owners and self-employed workers are 3 times more likely to rely on Penny for health coverage, and they're another highly impacted group. Over 100,000 get their coverage through Penny. We hear from small business owners all the time who have realized it's possible to pursue their dreams and bring value to Pennsylvania economy through small businesses, without putting their health at risk. Consider Jessie Green and her husband, Penny enrollees who live down the road in Lebanon County. Without the enhanced premium tax credits, their monthly cost would triple to $2,000 a month. To quote Jessie directly, "Who can do that? Even if you're a successful person, who can do that? It's too much." She also adds, "I'm not looking for a free ride, I'm willing to pay, but it has to be reasonable. Without that help, it becomes almost untouchable." Meanwhile, with the savings in place, Jessie and her husband are able to invest in their small business, in their community, all the time while managing their health. Speaking of small businesses, if the government were a business, extending the enhanced premium tax credits would be a no-brainer. Keeping more people insured reduces the burden of uncompensated care on hospitals, and early detection and managing chronic conditions reduces the need for costly medical interventions later on. Paying to keep people covered now reduces costs for the healthcare system later on. This is common sense. So if you take anything away from today, I hope it's this. Record enrollment at Penny, which we are very excited about, on the other hand, means more people than ever are at risk if Congress doesn't act. Without an extension of the enhanced premium tax credits, costs for Penny enrollees will increase by 82%, some seeing double, and the examples I gave 3 or 4 times more than they're paying today. This would reverse years of progress in reducing Pennsylvanians' uninsured rate, and the impacts to families would be felt at home, in the community, and Pennsylvania overall. Now, this audience crosses many viewpoints and stakeholders. We hope that you share these serious impacts that PA may be facing very soon. For more information, we have a webpage dedicated to this topic with data, consumer testimonials, and other articles about the impacts if Congress does not extend the enhanced premium tax credits. And that's penny.com/affordability. Thank you for your time. I'll wrap up here as I know there's another great panel coming up next. Thank you so much.
Thank you so much again to Devin Trolley, the Executive Director of Penny. We are going to get started with our second panel now. It's the Innovation in Pennsylvania Healthcare panel. I'd like to invite the panelists up here and welcome Justin Schweitzer, the Managing Editor of City and State Pennsylvania, who will be our moderator. Justin?
Just give everybody a minute to get back up here. All right. Thanks to those of you who stuck around for our second panel here today. I'm Justin Schweitzer, Managing Editor at City and State PA. And we've got a great discussion coming up. We're living in a time when technology is evolving at a rapid pace. And the healthcare sector hasn't been immune from some of these technological changes. We've seen how things like telemedicine services are helping more Pennsylvanians receive care. We're also seeing how AI is starting to transform certain aspects of the healthcare sector. And we're going to dive into all these things today and also take a look at what type of role the public sector is going to play in some of these discussions. So I'm just going to take a quick moment. We can go down the line if each of you want to introduce yourselves, state your title, and anything else you might want to share.
Sure. So my name is Arvind Venkat. I'm the state representative for the 30th Legislative District in Allegheny County. I'm also a practicing emergency physician.
I'm Rebecca Jacobson. Thank you. I am Rebecca Jacobson. I'm a physician and informaticist. I am CEO and president of Estrada. We are a Pittsburgh-based vertical AI company that works in measuring healthcare quality.
Senator Sharif Street. I'm a senator from Philadelphia County. I also chair the Banking and Insurance Committee, where I had the minority chair, where I had the pleasure of working with my colleague, Senator Vogel, on helping to shepherd through his bill for telemedicine.
Thank you. I'm State Senator Elder Vogel, Western Pennsylvania, Beaver, Butler, Lawrence County, and I'm chairman of the Senate Agriculture and Rural Affairs Committee.
Senator Vogel, I'm going to start on your end. I want to dig into telemedicine policy a little bit. After years of efforts, Governor Shapiro signed your bill into law requiring insurers to cover medically necessary healthcare services via telemedicine. How do you see this law improving access to healthcare in Pennsylvania?
Well, first I want to thank Governor Shapiro for signing this bill. It was a 10-year labor of love. Many of you in this room were probably involved as stakeholders and other people involved. I want to thank Senator Sharif Street as well here and his colleagues for helping many, many times. We voted this bill through the Senate and we get to the House and that's where it stops. But obviously this health care issue, as first panel discussed somewhat, the pandemic really brought it to light. I mean, we were working on this several years before the pandemic started, but once it happened and people that's the only way you could go to see a doctor. Everything was through telehealth. It's a bill that really just, we put the guide rails in place of who was going to pay for what and what was going to pay for who and how much hospitals and insurers were going to pay for in-person visits versus a telehealth visit and things like that. And that's what basically my piece of legislation did, was just put the framework in place to do this, and then the pandemic came along, and we really see how it's happened and how it's made a huge impact on not only rural folks but urban folks as well, because just the fact that someone who doesn't have the transportation or can't have the ability to take a bus ride across town to see a doctor, you can sit at home and you take your laptop or your tablet or whatever and talk to your doctor. I mean, that's happened during the pandemic. My wife had to have emergency surgery to have her thyroid removed, and so it's an hour for us to drive to Pittsburgh from where we live, and then you have parking and everything else, and she could literally sit at the dining room table and take her tablet out and talk to the doctor several times a week. And it was a couple of month-long project, because as they're adjusting your medications for your thyroid, why she was talking to the doctor sometimes a couple times a week, and that would have been trips we'd had been making to Pittsburgh, and she just sat at the dining room table to do that. So that's just one of the things, and just the access for rural health people, but even people in rural areas and urban areas to access health care is going to bring down health costs, I'm sure, because people now won't have to say, oh, I can't go to the doctor because I don't have a ride, or it's too far to drive, I can't take off work, I can't take off work to take my kid to the doctor. So it's another avenue to hopefully have better health care outcomes in the state of Pennsylvania and help drive down health care costs at the end of the day.
Anyone else want to add on that, on how that telemedicine legislation will improve access?
So telehealth has been a huge bonus in the emergency department, especially for rural hospitals. If you have a patient who shows up in a rural hospital and they're potentially having a stroke, determining whether they might need to be transferred to a larger center, say in the city of Pittsburgh, that technology and being able to support that financially through legislation like this is really, really critical. So kudos to Senator Vogel and Senator Street for having championing this for a number of years. But the unanticipated care aspects and how telehealth is being used, and also to potentially keep people out of the emergency department. A number of hospitals and health systems, Jefferson in Philadelphia, has really championed the use of telehealth in order to allow patients to talk with physicians and be examined virtually in terms of determining whether they might need emergency care or not.
Yeah, I just was going to add, look, to what Representative Venkat was saying. It has been, even in urban settings where you may have hospitals, but the emergency room wait can be really long. Getting people to get advice remotely so that people who don't necessarily need to present at an emergency room can get that advice without presenting. And then for people who may think that they don't need to present more quickly. We've seen both cases, and I think it is helpful in not just reducing the number of people that are there, and also having people present at a time that is where their symptoms aren't as acute.
Senator Vogel, I know you touched on the impact this could have on rural communities. What types of challenges do rural communities face that you see telemedicine playing a role in alleviating?
Well, as I briefly mentioned, just the fact of people having to take off work to drive long distances, like was mentioned in the first panel. If you have to drive from Warren, Pennsylvania to Pittsburgh or to Hershey or Philadelphia to see a doctor, people aren't going to take off work to do that. And if you have a child that has to go to a children's hospital someplace and you have to take off work to do that, those are just things that people will put off, especially not so much for their children, but for themselves. Oh, I have a backache, or this hurts and that hurts, and we won't do it because they don't want to take off work. It's too far to drive and things like that. And also the fact that in rural areas, broadband is an issue to a degree somewhat. We really found that out during the pandemic as well, that we have a huge lack of internet capabilities, but we're working on that through the state with our broadband initiatives and things like that. So hopefully over the next few years that will be not as much of a problem as it has been, but those are some of the issues. I think just the availability and lack of long distances people have to drive, and with the fact that rural hospitals are closing. I know I had one in my district, Elwood City Hospital, closed a number of years ago, and I believe right now the Sharon Hospital in Mercer County is probably closed as well, or they were having issues. I don't think the new buyer stepped up, so I think it's probably closed at this point in time. So when you're in a situation like that, you in Mercer County, if you're from Sharon, you drive to Erie, or you drive to Youngstown, or you come to Pittsburgh or something like that to get a hospital. You're an hour and a half or 2 hours away from a hospital. And so why would you have to go, if you have a minor issue, you would normally go to your local hospital down the road. Now you're not going to do it because, like I said, you can't take off work, it's too far to drive, and you have excuse after excuse after excuse, and then you end up having a heart attack and dying or something like that because you didn't take care of the symptoms because of the issues involved in getting there.
And to wrap up this segment on telemedicine here, Senator, I know you touched on broadband access and some of the challenges that that can pose. And I'll pose this to all three legislators here. What can state lawmakers do to help communities struggling with broadband access to help connect them to some of these tools that we're seeing available through telemedicine?
Well, there's a number of things. I think we can look at subsidized broadband access. We can look at it treating broadband access as a utility. It's something we need to think about, in that it is increasingly essential for people, and it's not the luxury that it once was. People access a number of vital services via broadband, and then I think we can look at making sure that there's appropriate infrastructure built out for rural areas where there may not actually be an appropriate build out. But in urban areas, you need to make sure that there is for rural and urban areas, you need to make sure that the price point is at a place where people can afford it. And I would just add, in terms of it being an access issue, it sort of struck me as Senator Vogel was talking about having to drive, an hour and a half to access healthcare, and people may not, get treatment that would ultimately have a heart attack. In Philadelphia, I live about 17 miles from where our doctor's office is in Montgomery County, and that could be an hour and a half drive on the wrong day, just because of the traffic. So it's 17 miles, and that could be 90 minutes, and for older people, that can be discouraging.
I want to shift gears to artificial intelligence now. We've seen a lot of ways on how that's being factored into our healthcare system. And I'm going to start this off pretty broad. What opportunities and concerns do AI tools present within the healthcare space?
It's a great question in many ways. It's the most important question right now as we're all kind of getting used to many of these new tools. I think in terms of the opportunities, I think we heard a lot in the last panel that we need to be mindful of. Right now, we are in a crisis that is borne by the demographics of our population changing, getting older, getting sicker, and we have a depleted workforce, which we're worried about. So the option of just increasing our workforce to manage this is really not an option. I think AI, if used properly, and I'm going to get to that in a second, has the potential to reduce the sort of administrative rote manual tasks that we are asking many of our providers, nurses, physicians, PAs, et cetera, to do, and to return them to spending more of their time in that one-to-one patient care, which is what they should be doing. In terms of the possible downsides here and some of the dangers that I think many people are worried about, I think a lot of it comes from, how quickly we are moving, one. Two, are we doing the right things with the AI? Should we be focusing, I tend to focus much more on these rote administrative manual tasks that need to be automated. And maybe we should be focusing more on those and less on tasks that are very high complexity, very high risk for AI systems to be involved in.
Anyone else on that?
So I completely agree with Dr. Jacobson that I have colleagues in Pittsburgh who are using artificial intelligence to do their patient note documentation, and it has been miraculous in terms of the reduction in administrative tasks that they have as a result. So I think that's a great example of the great benefits of artificial intelligence. I think the difficulty with the artificial intelligence is that in our society, we have huge disparities that exist on race, on gender, on socioeconomic status. And I'm certainly not the expert that Dr. Jacobson is, but from my own, educated reading, artificial intelligence systems are training on data that is as a result of our existing flawed healthcare system. We've done a lot legislatively to try and address and reduce discrimination and biases in healthcare. And if we are leaving artificial intelligence to be making decisions and we're not monitoring whether those biases are being reinforced, we could be going backwards in a number of different ways. And we've already seen examples of this. There's been a lot of discussion in the medical community about the use of certain algorithms and formulas that help to determine whether a patient is at risk for deterioration or certain conditions. And artificial intelligence has the potential to accelerate this because the amount of data that it can synthesize to inform a decision without an ultimate human decision maker. So that certainly has been my concern as a clinician and as a legislator of where do we strike that balance and what are the regulatory guardrails we put around artificial intelligence so that it can be a positive tool moving forward.
Yeah, just to build on that, I represent the Senate Democratic Caucus on the Sentencing Commission. I'm a lawyer, and while it's different, the base problems are similar. When we examined a risk assessment tool to look at the recidivism rates, the algorithm's data set that it looked at had implicit bias built into it. And there were members of the commission that wanted to adopt it. Ultimately, we didn't adopt it for the broad spectrum of purposes that we had talked about because the makers of the tool contacted us and said that it had an 11% racial discriminatory bias in it. And they said they created the tool and it wasn't ready for something like that. And the reason was because there was nothing wrong with the algorithm. There was something wrong with the data sets that the algorithm had to learn from. And so that there was an implicit bias in the data sets in the way that judicial decisions were rendered, in part because of juries and in part because of judges, and that the algorithm reflected that, and they were concerned that we would automate bias. There is concern about bias in terms of pain, where people present saying that there's pain. There's a lot of data that says that, particularly in women's healthcare, Black women, Latino women, women of color are less likely to be believed. And if you were to take those data sets in which the decisions were rendered by professionals, particularly when you're looking at historic data, where biases may have been increased the further back in time we go, and then automate them, you could potentially have implicit bias automated in a way that that person who is using the information is not biased, but now is using a biased data set and has new decisions rendered in a way that is unfair. And the second thing, if you're looking at it as an evaluative tool, a lot of the AIs have the base software that sort of the base code where they've examined people tends to be heavily weighted on either white folks or Asians, because it's Asians, and a lot of it's developed in Asia. And if you look at things like if you were trying to diagnose melanoma and the AI was looking at it, the complexion, the issues around complexion for darker skinned people are going to be very different than what would present for white folks or Asians. And so I think that we have to be very careful that we don't have implicit bias based in AI for all decisions, and it becomes that much more critical when we're looking at medical decisions.
Okay, so here's the easy question. How do we go about addressing implicit bias and making sure this isn't reflected in some of these platforms we're using and talking about?
So I think this is a crucial issue. And just to give you a little bit of the history here, I don't think it's necessarily specific to AI. In fact, many of us remember that some of the most important clinical trials done for MIs, et cetera, really didn't include women for a while. So this is a problem we have been dealing with as a medical and scientific community for a very long time. It's just so much more moving so much more quickly with these new technologies. The good news, I think, and I think the critical thing that we heard here, is that we must be mindful and aware of when our technologies are biased. And I'm glad to hear that there are groups that are, at least they know when their technologies are biased, and they can say something about that, because I think it's the first step to addressing it. There is some good news here, which is that there are techniques for minimizing bias in the training of these models. I just don't know that everybody knows about them, and they don't know how to apply them very well. One very prominent problem that we have that has to be addressed is we use data, sort of a little bit of a extrapolation of what was said previously. Part of the problem we have is that people in our most vulnerable populations tend to get less health care. They just present and they have less data. And therefore, these techniques that are used have to account for that and not bias it towards the individuals who have the most health care, who are obviously going to be in populations that are very specific.
So I had legislation last session, if you want to look it up, it's House Bill 1663 from the 23-24 session to try and regulate the use of artificial intelligence, primarily in insurance, but we were talking about extending it across the healthcare system. The challenge that we found when we had an informational hearing on this legislation was that the insurance department, rightly so, did not feel like they had the technical expertise to judge what was going on from artificial intelligence. And even within the technical community, they said, well, it would be nice if we had like test data sets that can tell us whether artificial intelligence is generating discriminatory outcomes. And I got very excited. I said, okay, that's great. Do those exist? Oh, no, not really. And so I hope I'm wrong, but this is the state of things right now in Pennsylvania and across many states. The insurance department, to their credit, through the National Association of Insurance Commissioners, put forward what was then the model bulletin saying to insurance companies, you have to follow the existing anti-discrimination laws in your use of artificial intelligence. However, the insurance companies are essentially attesting for themselves that they are following the law. And correct me if I'm wrong, but it's largely a black box process when data goes in and a conclusion comes out in artificial intelligence. That's true in hospitals as well, that are using it to supplement diagnostic accuracy. So as a legislator and as a citizen, I am very concerned that the technology is racing forward without a regulatory framework. I don't think we're ever going to have the technical expertise in state or federal government to get into the weeds, but we can't have the foxes watching the hen house, so to speak. We need to have regulatory guardrails around this. And we can legislate that, but implementing that in the current technology state we're in, I don't have the answer to that. And that's why the legislation did not move forward last session.
So a couple thoughts. One, in the law, we have something, we have a concept called disparate impact. And I think for right now, we are probably left with the unfortunate use of a tool with disparate impact. And the problem with disparate impact is you have to have a bad thing happen before you can correct. But disparate impact says, well, let's look at how the application of these, whatever this policy or tool is, over time. And if there is a disproportionately discriminatory impact on race or gender or national origin, then there must be some, I think it's substantial benefit that is considerable in order to overcome the fact that that impact is happening. And that's a tool that the Supreme Court has been using for a very long time for human decisions. I think we need to be cognizant and apply that to automated decisions that go in a black box and not assume that those decisions, because they were made by a machine, don't replicate our implicit biases. That's the first thing, and I think that's what we can do now. The second thing is, over time, we need to just be real vigilant to make sure folks are using better data sets. They don't just become reliant on old data sets. Data around medical information for people is going to get better and better as the cost of big data getting information about us, which presents a whole set of seconds of chances, it becomes more ubiquitous. Many of us probably are wearing an Apple or Samsung watch, smartwatch. If you are, it is measuring your heart rate, blood pressure, oxygen level, and a bunch of other things that you probably don't realize it's measuring, because every time it upgrades, it starts measuring more stuff. And now that these watches are only costing about $350 and the price keeps dropping, a greater and greater percentage of the population is wearing them. And so there's going to be real data sets on health for lots and lots of people. It measures how many steps you walk, whether you walk up the step, an incline or decline, how many hours you sleep, and a bunch of other things. Now, that presents a lot of privacy issues. But setting aside the privacy issues, big data is going to know a lot about all of us, regardless of race, color, or creed. And in theory, that could get more unbiased decisions if those data sets are used in a proper way. It also means that all of us, regardless of race, color, and creed, have less and less privacy.
Representative Venkat, as a physician and a legislator, I'm curious what your thoughts are on what an ideal regulatory picture for AI would look like. I imagine bias is something that needs to be addressed. Are there other key things we need to keep an eye out for as we talk about regulating it?
I personally think there are three critical issues. One is transparency to the public and to patients and to providers and to all the different stakeholders. I think when artificial intelligence is being used, we need to know that it is being used, and that needs to be clear in a way that it certainly is not now. The second is the bias issue. I think we're going to need to have some process for evaluating whether artificial intelligence is reinforcing biases. I don't think you're ever going to be able to eliminate it. I think that's a utopian wish, but I think there has to be evidence that you are minimizing that to the extent possible. And I think the third part is that there ultimately has to be an individualized human decision maker when it comes to patient care decisions. And that is extending not only on the insurance side, when we're talking about utilization review or prior authorization, it's also about clinical decision making. There was an interesting article in the New York Times, anybody can Google it if you do New York Times, artificial intelligence, hospitals and insurers. They're essentially in an arms race of using artificial intelligence in battle with each other for claims denials and trying to overcome that and appeals and this and that. And there was nothing about what is happening with regard to the patient. And artificial intelligence is being used by radiologists in diagnostic accuracy. It's being used by pathologists in diagnosis. It's being used in emergency medicine for, evaluating risks for life-threatening conditions. I am very concerned that we may end up in a circumstance where we just trust that artificial intelligence is giving us an answer based on a population-based probability, as opposed to looking at the individual patient and say, does this conclusion apply to the individual patient? So I think any legislation or regulatory framework needs to have those three components.
Yeah. Go ahead.
I just wanted to add that, there's a lot of national movement around figuring out how to use AI in a way that is safe. And I just wanted to point out that these very same three principles have appeared in many of the national initiatives to try to outline how to use AI safely. And I did want to comment on one thing that Representative Venkat said about the importance of having some external way to evaluate or validate these models. There also has been significant work, and I think we will see what's called kind of AI assurance labs, more centralized ways for more impartial, objective testing of models to determine things like accuracy and to elucidate the types of bias that may be present, and then to describe them and to be transparent so that users like healthcare insurance companies and providers and hospitals, et cetera, will know in advance.
So just a cautionary tale, going back a number of decades ago when I was in college, I interned for one of the what was then Big Six accounting firms, and there were probably only four left. And we were doing something that was a precursor to AI. very rudimentary. We were developing spreadsheets, and we had modeling in them, and computer modeling in them to determine what the payout should be for products liability cases, and what was considered, pre-litigation support. And there were a number of people who were potentially profiles of people that were inputted, and it was talking about what an appropriate payout would be for these folks. And the modeling would say sort of like, Representative Vincat, certain age, making a certain amount of money, certain potential. This would be the loss to his family if something went wrong and he died. And it would generate probably a pretty considerable number for him.
Maybe not so much.
Right. Well, we got to one guy who, these were profiles of real people we were inputting to test the system. And we got to one guy, and he was not a high performer in life. In fact, the system said that he was costing his family money, and the computer system yielded a thing where the family should pay the company for killing him. Because it said he was going to be essentially said he was a negative financial impact on his family, and that the family owed the company money because the product was going to kill him. And obviously that client did not use that system without modification. But it does show that a system, and for every other person, it generated a number that seemed fair. But when it does show that without a human looking at a system, a computer system could, analyzing a data set, come up with answers that no human being would ever come up with. Because there's something implicitly human that needs to be involved in decisions, particularly medical decisions. And so I could anticipate a situation where an AI decided that, hey, we have a patient on here who's going to need extraordinary care to live. We have 3 other patients that we could save if we let him die now and use the organs. Those are not decisions that any doctor would ever make. But an automated system making medical decisions could yield results that on some level we could see the logic in, but would be disturbing to all of us. And so I do think that we need to be cautious that there is a human element in these decision makings.
We're going to continue our conversation on AI in healthcare, but I did want to note we will have a Slido code going up on the screen. So when you see that go up, if you have any questions, feel free to submit them that way. Dr. Jacobson, I wanted to shift back to you here. I think AI can often seem complicated and a bit nebulous at times, but I wanted to see if you could walk us through how Astrada uses AI in its work and what that looks like in practice.
Sure. So as I mentioned, we are a company that helps predominantly healthcare insurers to measure healthcare quality, and obviously measuring quality is very important to improving quality. It's very important that we know the quality of healthcare that's delivered to every member, so that the healthcare insurance company can improve it, and so that their provider can improve it, and so that the member themselves can improve it. Unfortunately, it's quite difficult, really, to understand across a population, for all of the members of that population, what is the quality of healthcare, even though we have very good ways, very good measures that tell us we are doing the right thing for a hypertensive patient, or for a patient with diabetes, et cetera, or the right types of preventative care. It's still very, very difficult to understand, both at the population level and for individuals, what is the quality of care that we are delivering. So one of the things, I'm just going to highlight the one that's most immediately applicable to the question of AI, is that across the country, there are both on the provider side, almost every provider, regardless of their kind of particular degree, those people are spending a lot of time outside of their one-to-one sort of patient care responsibilities, documenting whether they have in fact done the right thing for that particular patient. This is additional to the regular, documentation that they're doing in the electronic health record. On the health plan side, the insurer side, there are large numbers of predominantly nurses that spend their time reading medical charts, actually all day long, reading medical charts to determine the quality of healthcare. And if you think about, what do we need to do as a country, I would argue that we need to have people working at the very top of their medical license or their clinical license and not at the bottom because we can't afford it. So our company basically uses artificial intelligence, especially the techniques in natural language processing, to act as a first reviewer, a triage, you could say, and to say these cases should be reviewed by a human and these cases don't need to be reviewed by a human because they're easy enough, we understand them well enough that we know whether somebody is compliant or non-compliant with the measure. So the idea here is get the human beings who are experts, who have been highly trained at high cost to make the important decisions, and where it's possible for a AI system to reduce the medical burden in this administrative task, we're going to let them do that. I hope that was sufficient to understand how we do that.
I want to shift gears a bit back to rural health. And Senator Vogel, I'm going to get you involved with a couple here. I know in preparation for this panel, we talked about how rural hospitals are facing a lot of challenges. And that could have a significant impact on access as well. What types of innovative solutions do you see available to protect and stabilize some of these facilities that are really a lifeline in these rural communities?
I would say, like I basically mentioned earlier, that the telehealth is a huge lifeline, and also the fact that different hospital, I know UPMC has their buses they take around into communities and go to different places, and the healthcare buses, I forget exactly what the name of them are called, but I know I've seen them around at different events. They have them at community days and things like that, where they have a bus there that you can go in and get some health checkups, blood pressure and things like that done. I think that's, in fact, that the hospitals are going away, and these are the kind of things that are going to have to step up to fill the void for people in rural areas and even urban areas to be able to get some kind of health care, get at least a baseline on your health care, your blood pressure and your weight and things like that. And it's a simple thing to do because with the hospitals going away and farther distances to drive, like I mentioned earlier, it's just going to be harder and harder for people to get good health care. And things like this is what we're going to have to do, the innovation with AI and things like that, or where we're going to have to go forward in the future to take health care to the people. Since the people can't come to the health care, we have to take it to them, I guess is.
Another issue you've raised in our conversations is mental health of farmers and agricultural workers, and connecting those people with services that they need. And I know the Department of Agriculture established a mental health helpline for agricultural workers. In your work on this issue, what types of mental health challenges are farmers and those rural communities facing, and how do you see this tool, a simple helpline, helping connect them to types of services that they might not otherwise seek out?
Well, in the rural areas and farming in particular, I milked cows for 50 years, and I can tell you, last week when it's 10 below zero, your life goes from a 10-hour day to a 15-hour, 20-hour day, because every time you turn around, something is froze or something is froze again, or it's not going to thaw out today, and that just puts a lot of stress on you. And then more people I actually had a roundtable with Secretary Russell Redding, came to Beaver County back in 2018 or 2019, and we had 10 or 15 farmers sitting around talking, and I never forget this one lady. She said she lived on a farm up north, I think Mercer County, I think it was. They milked 300 cows. The only interaction she had with any other people was once a week she went to Sheets to get gas in her pickup truck. That's the only interaction she had with anybody all week, was driving to Sheets once a week to get gas in her pickup truck. And you go into the Midwest where these people live on thousands of acre farms, and they're a couple hour drive from even Walmart. I mean, it's just a very thing to do. Then you have prices and weather and different things like that. You have animals. Animals always have health issues. And all those stresses build and build and build on people, and people don't know how to take it, and just the loneliness of being no one to talk to. So the fact that they've had this agri-stress hotline, a 24/7 hotline, we got $500,000 grant here in Pennsylvania to implement it here for rural people and farmers in particular in Pennsylvania. It has 160 languages, So any language you are in Pennsylvania or any place you can talk to somebody, and talking to somebody that knows farming and knows what you're going through is different than you talking to somebody from Pittsburgh who doesn't have a clue what you're dealing with in your farm. It makes a huge difference as well, because you're talking to someone that knows what you're going through, and it's a huge issue, and it's a big help, because obviously it's not only farmers, but other people have mental health issues, and telemedicine is another issue where, like it was mentioned earlier, the young kids that can't see the doctor, they can go after school and get online and meet with their psychiatrist or psychologist or whatever, and do things that way. And it's the same way for farmers in the rural community as well. It's just something that's very important. Mental health is now not so much a taboo issue as it was. More and more people are talking about it, but still the suicide rates in the rural areas and the farming community are still way above the national averages for just the average person and stuff. And it's just because of the issues they deal with, and the loneliness and being away from people, and just all the issues that go with farming.
Okay, it's Slido time. We're going to shift to some of these questions on the screen. The first one is, should AI systems specific to healthcare be built on open source models exclusively to ensure the transparency component that was mentioned earlier? Anyone want to touch on that?
Yeah, I wouldn't be in favor of that, because I don't know how you vet the quality and the accuracy of the open source data. I would assume Dr. Jacobson has a more informed opinion, but that would be my concern, that there needs to be some vetting of what is going into the training of these models.
So one of the things about open source models in general is that they tend to share much more about the data that they are derived using, as well as sharing the actual model themselves and the weights around these models, which is kind of the thing that makes it all go. And a lot of transparency. They tend to be way more transparent than the closed source or proprietary models. I think a lot of the advances that we are seeing actually came because there was a period, it's been a long story, but with every advance in AI, we've seen first huge money go in, create proprietary models, and very rapidly after that, much smaller but innovative teams come and develop open source models that then are shared with the entire community. And because of that, we know much more about these models. They're much more transparent, and they offer a way to sort of let us move forward with much better understanding. So in general, I think it's essential that we support the open source community and the development of these open source models, because I think they're going to lead to much better technology, much more transparent technology. I would not want to see a limitation on that, just because I think, there's other ways to skin the cat. But I think in general, these communities developing open source technologies, including open source AI, need to be supported.
I would just say that I think, echoing a lot of what Dr. Jacobson said, I do think that open source modeling has demonstrated really good results in terms of innovation and the development of innovation, and there's going to be more transparency. But I think it is unrealistic to suggest all of it is going to be open source, and therefore I would say we probably need to have a peer review process that's put in place for non-open source products, because essentially you get peer review in open source organically, so there should be a mandated peer review process like we do for other medical products, and recognizing that you can't get a medicine or a treatment regimen they can't be universally recognized without some kind of peer review study. There probably needs to be a peer review process for healthcare-based AI-specific models. I just think that's probably the best way to address those challenges.
Next question is, with Google AI telling people to eat rocks to solve their health issues, what can be shared about curbing the harm caused by DTC AI tools and products?
People should not ignore common sense when they look at an AI tool. If it tells you to eat rocks, you should not do that.
Shifting back to, anyone else on that? No?
I agree, don't eat rocks.
Shifting back to telehealth for a moment, is there a negative impact on healthcare workers with the increased patient load due to telehealth making care accessible? And how is that being dealt with, if that is the case?
So I haven't seen that. Like I said, I continue to practice as an emergency physician. There are a lot of emergency departments that use telehealth as part of their triage process, and there's a lot of health systems that use telehealth as part of their way to continue follow-up. I haven't seen that contributing to adverse patient load. What is contributing to adverse patient loads is the fact that we have an aging society, and we have, as a result, more health burdens, and we have a healthcare reimbursement system that is incentivized towards certain high-dollar proceduralists and not enough towards the care of patients across a continuum of healthcare issues. So I don't think that technology and innovation in telehealth is a problem in this regard. I think we have much bigger problems that are contributing to that.
And when talking about data sets and AI, how are missing data sets being addressed, like data on individuals with disabilities, for example? Anyone want to take a shot at that?
I'll say that I know that there's a lot of interest in this at the national level, at the NIH, for example, where people are starting to talk about, maybe we ought to be not just funding the new technologies, but actually funding the development of specific data sets, because they are so important and they are missing.
I think the other thing that we are facing is a loss of trust in technology and expertise. I see it even in my relatively affluent, suburban, educated community, and we are seeing it nationally, where they're, especially coming out of the pandemic, there's a huge amount of skepticism and with regard to medicine, healthcare, science, conclusions that are as a result of the scientific method. And so at a fundamental level, when we're talking about AI and data sets, again, it goes back to who is validating that we are getting a representative sample. And I at least don't have an answer to that at this point.
I think we're about out of time for this panel, but again, I'd like to thank my 4 great panelists here for a very engaging discussion. So thank you all. And I'm going to turn things back over to City and State Editor-in-Chief Greg Salisbury.
Remember, don't eat rocks.
Words of wisdom. Thank you all for that discussion and taking the time to share it with us. I'd like to thank our sponsors once again, UPMC Health Plan, Moravia Health, the Hospital and Health System Association of Pennsylvania, PHCA, the Wright Center for Community Health, and Jackson Kelly. Be sure to stay connected with City and State by signing up for our First Read newsletter at cityandstatepa.com. We hope to see you at the Black Trailblazers reception in Philadelphia on February 25th. Thank you so much for being here today. Have a good day.